My name is Sarah. I am part of the marketing team at Fullscript, and we are very excited to have Tracy here today to join us for this webinar. Before we get into the presentation, I want to go through a little housekeeping first. So just a reminder that this recording will be sent to everyone who registered. So if you have to leave a few minutes early or just want to watch it again, you will have access directly from your inbox. The recording will also live on Fullscript's website, where you can access all our past and upcoming webinars as well. Throughout the webinar, if you have any questions, please add them to the question box, and we will get to them during the live Q&A at the end of the presentation. With that being said, I am going to pass it over to Tracy to take it away, and I will rejoin you closer to the end of the webinar for a live Q&A.
Okay, great. Thank you so much, Sarah. I really appreciate that. And I want to thank Fullscript for the opportunity to bring some applied functional medicine education to all of the practitioners who take advantage of the wonderful service here at Fullscript. I am the founder and principal instructor at the School of Applied Functional Medicine, where we teach a rich diversity of healthcare practitioners about using the science of functional medicine in clinical practice. And this is an important distinction because what we've seen over the past 15 years, that functional medicine has become well established and increasingly well known, is that there's very much a difference between knowing functional medicine science and then being truly savvy, truly capable and confident in applying that science in a clinical context in order to maximize outcomes. And so today's presentation is an opportunity specifically to share some of points of both art and science for practitioners who are looking to counter the omnipresent challenges with irritable bowel. This is a somewhat ubiquitous bucket now, a label that we give a rich diversity of gastrointestinal symptoms of distress and imbalance. And many individuals in our practices struggle with this, but perhaps most importantly, people struggle to experience lasting relief from IBS. They may get well temporarily, but then they will struggle with recurrence or maybe just temporary improvement and then eventual exacerbation. And so my purpose today is to share with you a number of different insights that you can use in your practice right away in order to improve your satisfaction as well as your patient's clinical outcomes. And I want to start by introducing you to two people. This is Jack and Joanne. Jack was at the time, a 57-year-old physician who was thinking about early retirement until he discovered functional medicine and became wildly intrigued about the possibilities of using functional medicine in order to approach patients in a different way. And it really galvanized his passion for his practice and gave him an avenue for falling in love with medicine all over again. Joanne at the time was a 28-year-old female who had been struggling for many years with persistent IBS symptoms, in particular, quite a bit of cramping, bloating, and distension in her GI tract. And I start by introducing you to two people because I know that as much as all of us love the intellectual, the mental challenges of functional medicine and of getting at the roots of a unique case of disease. Ultimately, I believe one of the things that connects all of us is not just our heads and our hands in doing the work, but also our hearts. And the primary reason we pursue this admittedly quite challenging work is because we care about the people. We care about the people. And the reality is that Joanne was suffering greatly and was really feeling somewhat hopeless about getting some relief. Her primary care physician and then two different GI referrals had not been able to give her any type of lasting relief rather than temporary symptomatic improvement. And they came together in a savvy clinical partnership and were able to work together over a 4.5-month period in order to achieve what both of them previously had thought might not be possible. And we bring to light really the humanity of clinical outcomes This is a verbatim excerpt from a message that Joanne shared with Jack's office when they were following up with her, even 3 months after they finished their program together. And this is a young woman. Yes, I'm feeling so much better. I'm happy my joints have stopped hurting. I'm thankful. And now I know foods that my body does not want, so I can help myself. Really experiencing a level of vitality that had not been hers for over a decade. And at the same time, Jack experiencing himself an amazing clinical outcome. Again, verbatim in his own words, I have to say I continue to marvel at how effective this whole realm of functional medicine is proving to be. This late in my career, I never expected to learn so much about the actual causes of disease. This is great stuff. And Jack is still in practice now, several years later, having, as I said, experienced a whole new resurgence of passion and commitment to his medical practice, but showing up in a different way and maximizing the outcomes, not just for the patient, but also the satisfaction, the fulfillment for the practitioner. At SAFM, we focus on both because they're both essential to the longevity of healthcare transformation. But I want to use this story in order to cue up many different learnings and insights about IBS. I'm going to be talking a bit about some of the most common functional imbalances that are at play in IBS. We're going to talk about some of the most often overlooked components of chronic GI distress. We're going to talk about a few other cases, and we're going to dive into both Joanne's case as well as Marilyn and Jose's cases about what was at play in their unique case of IBS and what was necessary to actually get at the roots and resolve it. And across the 3 diverse cases, I believe you will pick up a number of clinical tips that you can apply in your practice as well. And then we will talk a bit about some of the underlying fundamental root causes of disease that we see at SAFM all the time, tens of thousands of cases later. These are the things that are most often at the root of recurrent disease. And then we will wrap up with a few particular common challenges and ways that they can be addressed with regard to recurrent gut dysfunction. But I want to just start off here with a critical truth about functional medicine and the lens it has. In the same way that we would never try to resolve disease in an individual leaf on this little bonsai tree, we would never try to focus myopically just on the leaf to the exclusion of everything else. Of course, we know the health of the leaf is dependent on the health of the stem and the stalk and the limb and the trunk and the bark and the soil and the roots and the air and maybe the garden overall and the bonsai tree's neighbors in the garden. We necessarily understand from a systems engineering perspective that everything is interconnected. And in healthcare and medicine, this is true not only in an individual's physiology and biochemistry, right? We can't separate what's happening in the gut from what's happening in the liver, or from what's happening in the joints, from what's happening in the brain. Or in the heart, or in the pancreas. Everything is interconnected. But going even beyond that, we must look at an individual's entire life system. We can't separate their state of IBS from their level of stress, from their typical sleep experience, from their typical life outlook and attitude, from their typical dietary intake. Everything is interconnected. And so in this sense, it is much wiser for us to look at an individual case, not from the lens of what kind of disease does this person have and how do I quickly jump to a diagnosis and treat it using a standard of care, but rather who is this person? And as a result of that, what is the type of dis-ease or imbalance in their normal physiology and biochemistry that they are experiencing? And by seeing what makes this person unique, we can most readily get helpful and appropriate cues and clues on the roots of disease in their unique case so that we can not just improve it or manage it, but ideally we can get at the roots and actually make it go away. Now, IBS is a wonderful framework for learning more about functional medicine and for picking up more prowess and wisdom in clinical practice. Because, like so many other diagnoses, IBS or irritable bowel syndrome is a label that we have agreed to give collectively as a profession to a certain set of symptoms. But we know, of course, from our own clinical practice that what is at play in creating that particular symphony of symptoms is going to vary. And indeed, as I said earlier, if we want to help the suffering to actually go away, we have to get at the roots. Certainly, there's a lot of maldigestion at play in promoting IBS, but the causes of that maldigestion, the particular types of the maldigestion can vary. Does a person have hypochlorhydria or insufficient stomach acid in the gastric cavity? Maybe as a result of medication use, maybe as a result of an overgrowth of H. pylori bacteria. Or maybe it has nothing to do with stomach acid. Maybe it is about pancreatic insufficiency. Maybe it is about an aggressive immune system response to a food like gluten in the intestines, which is creating oxidative wear and tear to the mucosa and impairing our ability to secrete brush border enzymes in the intestines. And that is impairing digestion of foods, which is leaving more food fodder available for promoting a microbial overgrowth. And the byproducts of that overgrowth are promoting IBS, right? People can have one or two or three, or maybe none of these, right? Maybe they have great digestion, but they struggle with excessive immune hypervigilance and inflammation in their gut, in particular in their intestines. This might be creating, as I said, oxidative wear and tear to the mucosa, which might be having inflammatory effects that are creating dysmotility, for example, or higher levels of stress hormones, maybe higher levels of histamine, all of which can create IBS symptoms. Or maybe a person has none of those. Their digestion is working fine. Their immune regulatory balance is in a good place, but they have dysmotility. Perhaps that's secondary to hypothyroidism. Perhaps that's secondary to serotonin imbalances. Maybe they have inadequate levels of tryptophan, the essential amino acid that is keeping them from producing optimal levels of serotonin. Maybe they're taking medications that over time are depleting serotonin levels. Or maybe it's not that at all. Maybe they have inadequate levels of magnesium, which is essential for controlling relaxation and contraction of muscles. Magnesium acting as a bit of a master electrolyte in controlling the movement and activity of potassium. Or maybe it has nothing to do with either of those. Maybe this is primarily about stress and an individual struggling with more a sympathetic dominant nervous system mode, which naturally promotes dysmotility. It can also naturally promote maldigestion by impairing digestive secretions. But you can start to see how if you've seen one case of IBS, you've seen one case of IBS. If your goal is really to provide substantial lasting relief from the suffering by actually getting at the roots of disease in this particular area and making it go away. Dysbiosis is involved in a lot of IBS, but not all IBS. Lots of times functionally medicine-oriented practitioners fall prey to the root cause of the day, right? As we learn more about Lyme disease, it feels like everyone has Lyme disease, just like we used to think everyone had Candida albicans overgrowth, or everyone has mercury toxicity, or everyone has insulin resistance, right? We are wise to try to maintain beginner's mind and the ability to not get distracted by a level of aggressive certainty early on in a case, but to keep a level of wise restraint and being present for the unique individual in front of us so that we can better hear and see what is uniquely at play with them. Because if we want to get at the roots and make it go away, we've got to be able to identify what is actually at play. Now, I do want to speak about the importance of relief, because I've talked quite a bit about getting at root causes, but symptom relief is important. There are many factions within functional medicine, some that focus primarily on symptom relief. And often, certainly, we have a lot of professional beliefs that maybe that's the best we can do in some cases. Although I certainly have seen well-applied functional medicine bring lasting relief in highly entrenched cases of disease, including when they've been at play for decades. So getting at the roots is really important, but rapid relief is an essential part of galvanizing your patient's belief system. Galvanizing their belief in you as a practitioner, that they can get some relief to some degree fairly promptly in order to help to galvanize their belief in their overall ability to heal, period. A lot of people who are seeking support from a practitioner through the functional medicine lens have been suffering for a really long time. They've already tried multiple practitioners. They've already worked with their GP or their primary care provider. They've already had multiple referrals. They may have already been to 1 or 2 or 5 other alternative practitioners. They often are jaded, frustrated, maybe hopeless. Maybe you're the last person they plan to see to give it a try. And so in order to help to galvanize their patience, their commitment to the journey that we know it takes to get at the root cause of disease, because it's not a quick fix, we must help to give them rapid relief that helps them to realize that there is hope. You are capable, and they are capable of actually getting well. And so I'm just sharing with you here what I hope is just a good reference sheet for a number of different aspects of relief. This is really essential also for stabilizing what can be a tremendous amount of dysfunction. And for example, if someone has chronic diarrhea in their particular case of IBS, as we know, it can be really hard to help them to say, hydrate well, which is essential for normal cellular metabolism and function. Hydration is actually really essential for motility, regular motility maintenance. If a person has diarrhea, it's really hard to replete their levels of magnesium so that their motility can be balanced. It's hard to replete their levels of zinc to have optimal immune function, because there's rapid transit time. There's not that much absorption of a lot of different nutrients, and there's a tremendous amount of nutrition loss in those loose stools. And so being able to use targeted supplements, and of course, Fullscript has an incredible and rich variety of high quality options in this area. Whether we look at microbial modulation for helping some of these, such as Saccharomyces boulardii or Lactobacillus plantarum, excellent remedies for being able to quite promptly reduce rapid transit time and perhaps fully stop the diarrhea, or being able to do it more from a binder perspective with, say, bentonite clay or activated charcoal, being able to modulate the diet. These are really important items. Similarly with bloating and distension, if you're trying to help an individual to make dietary change where maybe food is part of the problem with their case of IBS, if pretty much everything they eat makes them bloated, then they're going to have a hard time following through on the lifestyle change. And so being able to get some support for bloating and distension so they feel like they can comfortably eat to some degree is essential. It's not optional in terms of helping to ensure clinical success. And so this is where, in particular, carminative herbs such as fennel and ginger, peppermint can be really quite effective. Just use caution with peppermint, which if the acid reflux is part of a particular presentation. Peppermint can actually exacerbate acid reflux. And so there are a number of different tools here to consider, but just to highlight that in the argument in the functional medicine world about symptom relief versus root cause resolution, optimal clinical outcomes require both. If you take too long for someone to get some really not full, but really inspiring level of relief, they're probably going to wander away from you and your practice before you've had the opportunity to have a substantial impact. But at the same time, if all you do is focus on rapid relief, then someone may be a fan for a month or two, but they're not going to get that full resolution. There will be recurrence or eventual exacerbation of their suffering. You're highly unlikely to get those truly raving fan reviews and testimonials that can be such an essential part of your practice marketing. And for that matter, helping people to really get lasting relief is such an important part of practitioner satisfaction and fulfillment. We want that for you just as much as we want it for them. But I also want to talk for a bit as we think about the roots of IBS. We've come a long way in functional medicine. If you go back and look at where we were 15 or 20 years ago when I first started getting passionate about functional medicine, there are a lot of things that functional medicine has established and really promoted, and now is widespread knowledge in an awful lot to large populations of progressive practitioners. We know that these are truths. These are aspects of clinical intervention with IBS that functional medicine really gets right today, and that the vast majority of practitioners well understand. But there's still quite a world of concepts that we've really only begun to thoroughly explore more recently, that I think is really going to shape an awful lot of research and clinical wisdom in health overall, but especially in IBS over the next 5 or 7 years in particular, right? We're learning that dysbiosis in the intestines often begins in the mouth. It's fascinating how often we treat dental health and intervention, or even oral health, as being somehow separate from the rest of the systemic body. We know that so much disease begins in the gut, then we would expect logically for so much systemic disease to begin in the mouth, because the mouth is the top of the gut. For that matter, eating hygiene is an essential part of healing from IBS, in a way in which patients must participate. I believe this is not optional, because it is the only part of digestion and absorption of nutrients that is voluntary. And to the extent that a patient does not practice optimal eating hygiene, their entire physiology below the mouth has to deal with the repercussion of that. And it makes the task of having good gastrointestinal balance and function way more challenging. I think we're just now starting to understand just how much motility is oh so often involved in chronic IBS, and that dysmotility, again, is not just about maldigestion. For that matter, it's not just about SIBO, or, as I said before, hypothyroidism. We are learning so much more about the impact, for example, of the vagus nerve, and how essential optimal vagal tone and transmission is from a parasympathetic nervous system perspective. And stress, especially chronic stress, can be a major contributor to dysmotility, one that people often don't get educated about, so they don't become aware of it and change it. For that matter, the synergistic relationship between motility and insulin regulation, and how things such as type 2 diabetes can be a major contributor to dysmotility that then precipitates downstream GI disease. And then that GI disease makes the metabolic dysfunction worse, and the metabolic dysfunction worsens the GI imbalance, and we get a forward feeding disease cycle. It's not enough to address one. We can't just address the diabetes or just address the IBS and expect lasting relief for the patient. We have to address both and have good clinical wisdom on the synergy between these two systems. In the very strong presence of long haul COVID and post COVID, we have to understand that any disease that is affecting ACE2 receptors is likely going to have some expression and maybe exacerbation in the gut, where we have actually a lot of ACE receptors. And this can, on the other side of or in the middle of a strong bout with COVID, we can have tremendous oxidative wear and tear to the gut lining that can create maldigestion of nutrients. It can actually precipitate a loss of barrier function in the gut, enhanced intestinal permeability. We need to be looking for this in all of these long or post-COVID cases. For that matter, there are behavioral things that came along with the pandemic, such as a really marked increase in people's alcohol intake. It's amazing to me the number of people who maybe only occasionally drank alcohol prior to the pandemic, but they developed the habit during the pandemic of drinking way more regularly. And now they routinely have a couple of drinks every single day. And the role of alcohol in creating damage to the mucosa in our intestines and creating gut dysfunction, in addition to the other downstream toxicity effects. And so on and so on. We could do a whole talk on just any one of these individual bullet points. And we teach about all of these things at SAFM because practitioners need to be looking at and considering all of these things. Again, this can be a good list for thinking about, what am I missing when there is a case of entrenched IBS that's just not resolving, or it seemed like it was gonna stick, right? The resolution was gonna hold, but 3 months later, the symptoms are back. 4 months later, the symptoms are back. IBS is one of the most common recurrent disease dynamics. And another challenge that we see in the functional medicine world is how often practitioners are expecting a comprehensive stool test to be the primary tool that they need in order to resiliently address any GI imbalance, including IBS. And as much as we would all like for health to be that deterministic, that there's one test that just will give us all of the right answers, the reality is that a stool test is a single point in time that tells us what is happening in a veritable planetary level complexity in the gut microbiome. And too often we are looking to affect GI function by controlling the microbiome. And then we're surprised when a gut disease recurs or actually doesn't get better, it worsens. The reality is that the microbiome is incredibly complex, and we're actually just learning in the past several years the difference, by the way, between what's actually happening in the gut versus what shows up on a stool test. Because at the end of the day, bacteria don't really want to exit the gut and be measured in a stool sample. They want to thrive, especially in the rich biofilm and the synergistic environment that they find in our GI tract, especially in our colon. And if we want to modulate the gut so away from a disease-promoting dysbiosis, we have to change the terrain in which we are asking the microbiome to thrive. Too often we're focused on find the bug, kill the bug, assess the microbiome, fix the microbiome. And that is almost by definition going to be very limited. That doesn't mean that there's not incredible utility for a comprehensive stool test, but we're too quick to jump to that as a first assessment and too quick to assume that if we treat a stool test, people will get better. And we've seen it many, many times over the years, right? You run a stool test, you treat it, people feel better for what? 4 weeks, 6 weeks, 2 months, maybe. Or maybe they don't feel better at all. Actually, maybe treating it makes things worse because treating one thing allows a secondary dynamic to emerge. And so we've got to address the underlying terrain aspects, right? The functional imbalances in the gut that actually promote disease. As we know, this is helpful not only for addressing IBS and official gut disease, but because what happens in the gut very seldom stays there, but spreads systemically and affects the health of the joints, the health of the brain, the health of the heart, the health of the liver, right? The health of the left big toe. By doing this, by focusing and really mastering how to optimize the terrain in the gut, we actually empower ourselves as practitioners to be way more effective at alleviating sustainably systemic disease. Now, I introduced you to Joanne already. Joanne, as I said, was a 28-year-old woman struggling with a lot of cramping and bloating for about 8 years. And at the roots of Joanne's case of IBS, which had not been recognized in any of the referrals she received, was actually a really marked food sensitivity to dairy foods, which had created some enhanced intestinal permeability. That was also probably promoted by her vitamin D deficiency, by her longstanding use of oral estrogen-containing contraceptives. And this was therefore creating a systemic inflammatory dynamic that was causing quite a bit of hip, shoulder, and knee joint pain. And not surprisingly, Joanne's mom recounted from her early childhood how much of a colicky baby she was and how she struggled with multiple ear infections as a child. These are common hallmarks, actually, of dairy sensitivity. But as a result of that, what Joanne needed in order to get lasting relief was very different than what Marilyn needed. Marilyn at the time was a 70-year-old woman struggling with quite a bit of dysmotility, in particular, a lot of bloating and really loud aromatic flatulence, which was really embarrassing to her. And at the roots of her particular case was actually some dysbiosis and also some maldigestion that was being caused by poor gallbladder emptying. And we were able to get at the roots and understand that Marilyn had hepatic biliary congestion. That was likely as a result of her insulin resistance, but also, even though she was postmenopausal, likely the result of excessive estrogenic activity, contributed by her obesity, because we know even postmenopausally, right, adipose tissue is endocrine tissue and body fat is fully capable of making estrogen. And also Marilyn's longstanding beloved use of personal beauty products. She was very passionate about all sorts of creams and tinctures and potions to keep her skin beautiful. She got her nails painted every week. She dyed her hair to keep it nice and dark on a regular basis, getting a huge regular exposure to all sorts of phthalates and other endocrine disrupting chemicals that can have notable estrogenic effects. And so what Marilyn needed to actually fully resolve her case of IBS was really different from Joanne, but it was also different still than from Jose. Jose at the time was a 51-year-old new grandfather who was struggling with constipation and also the classic symptoms of bloating and distension from IBS. And he was frustrated because other than an early pre-diabetes wake-up call, he felt like he had been a really healthy individual. And what we found out through further investigation in Jose's unique case was that he had maldigestion due to pancreatic insufficiency. And it's an important clinical tip for all practitioners that all types of diabetes, regardless of their stage of progression, including type 1 diabetes, are vulnerable because of the endocrine pancreatic insufficiency. There's strong evidence in published research that exocrine pancreatic insufficiency is also prevalent, depending on the study you look at, in between 25 and 50% of patients who have an endocrine pancreatic disease, some type of insulin challenge. And this creates impaired release of digestive enzymes that, of course, end up creating maldigestion and lots of excessive food fodder in the intestines that is available for excessive fermentation that creates a lot of opportunistic overgrowths. And then the byproducts, the metabolites from those overgrowths, can impair our motility, can influence levels of serotonin, can create wear and tear in the mucosa in the intestines, and create challenges. But what was interesting in Jose's case is that he had an exceptionally good diet. It was already low glycemic. It was already full of homemade meals with healthy whole foods. And what we were able to uncover that the roots of the high glycemic load in Jose's life were not so much about his diet, but more about his stress. And not mental emotional stress, but physiological stress. In his case, likely long-standing but unrecognized and undiagnosed sleep apnea. Jose actually had markedly low levels of cortisol, a sign of a more advanced maladaptive dysregulatory stress state. And this was actually had over time created glycemic challenges for him. And so again, obviously getting at the roots of Jose's sleep apnea, getting at the roots of Marilyn's hepatic biliary congestion and poor gallbladder emptying, or getting at the roots of Joanne's food sensitivities and enhanced intestinal permeability. These are three very, very different cases of IBS, right? The solutions, the tools, the interventions are all well covered within the practice of comprehensive applied functional medicine. But we must master our ability to really keep beginner's mind and find what is at play in a unique individual. And when you do, you will create raving fan patients and clients who absolutely can help you to build your business. Because when you have that keen focus, when you have that targeted approach, rather than here's the standard thing we do for all IBS-D, or here's the standard thing we do for all GERD, you can accelerate recovery. You can become known as a true expert in your field, and you can dramatically improve your professional satisfaction and also your clinical outcomes, which makes raving fans that get you those incredible testimonials that your patients are looking for when they're trying to decide whether or not they want to become your new patient. I want to expand from these three cases to talk about additional key components of causality of IBS. And I want to use a simple diagram here. At SAFM, we talk quite a bit about chains of interconnectedness, which is really about this cascade, if you will, of progressive interconnected causality. We know that downstream, right, in terms of outcomes, we may see a IBS diagnosis, and the hallmark symptoms are well understood, right? Some degree of cramping and pain, fatigue, diarrhea and or constipation, bloating and or gas. This part is really straightforward. But as we begin to turn our focus upstream in what is actually causing, what is precipitating those symptoms, and looking beyond just symptom relief, we start to see what are the actual GI functional imbalances that can be at play. Well, dysbiosis, dysmotility, maldigestion, and food sensitivity, all present in the cases I just quickly summarized for you, are the most common ones. But even if you identify these, and unfortunately, a lot of practitioners stop here, that is not enough, because of course we have to go upstream from that and identify the particular type of functional imbalance, right? What is actually at play? And then even go upstream from that. What is causing that functional imbalance in the gut? And as we know, often what is causing a gut imbalance is at play elsewhere in the body or in the life system. These are some of the most common behavioral choices or other disease dynamics that can precipitate the functional imbalances in the gut that might eventually lead to IBS. But even this isn't enough. We still have not gone far enough upstream. In particular, I believe every practitioner who is using functional medicine in their practice needs to become truly masterful in understanding the role of nutrients. Because way too often, what is in the way of lasting relief, or what is actually creating a disease dynamic, is long-standing insufficiency. Not necessarily clinical deficiency, but insufficiency for that unique person's needs, given their genetics, given their lifestyle, given their environment, given their other diagnoses and medical history, not enough nutrients. When we talk about dietary guidance, we tend to focus collectively way too much on macronutrients, which is important, right? The right amounts of healthy fats and protein and carbohydrates and fiber and the role of fasting, all of these kinds of things are important. But 100% of the human body's physiology and biochemistry runs on micronutrients. And so we don't have a pantry in our left butt cheek of extra zinc or extra vitamin D or extra vitamin B6 if we need it. As we progressively have insufficient levels, our biochemistry just does not work optimally. And so we shouldn't be surprised that downstream, people develop histamine intolerance, people develop fatty liver, people develop hypothyroidism, people develop a hypervigilant immune system. Of course they do, because those functional balances require nutrients. But if we look even upstream from the nutrients, we find an awful lot of basic life habits, day-to-day lifestyle choices that people are making, and maybe they've been making for years. And because it's what they've always done, it doesn't occur to them that this could be a major contributor to this disease that I've just started really suffering from in the past year or two or three. Oh, they don't necessarily think that the body has actually been struggling under the burden of these choices for a really long time. And it has tried to span the space, but it simply is now out of balance, where it no longer has the capability. It no longer has the resilience to withstand these choices. And so we're seeing dysfunction in our physiological systems. But these are some of the really common choices that people are making on a day-over-day basis. Again, often well in advance of a diagnosis. And then perhaps most insidiously, even upstream from that, we will find the socio-cultural norms in many of our communities, many of our cultures, our countries, that are the foundation of which is on a nutrient-poor, calorie-rich, chemical-rich diet, which I like to call crap food, excessive exposure to an incredible variety of toxic substances, and stress, every imaginable type of stress. Mental stress, emotional stress, social stress, environmental stress, toxic stress, infectious stress. So often at the roots, we find these types of choices. And for sure, people are ignorant most often about the role of these choices, because in their mind, they're just being normal. They're eating what everyone else is eating. They're slathering the same personal hygiene and beauty products on themselves every day that their mother is, that their sister is, that their neighbor is, that the advertisement in the magazine told them to. They're struggling from the same types of stress that everyone they know and love is wrestling with. And especially here in the US and in many other, unfortunately, increasingly other cultures, not only are we laden with stress, we actually think we're thriving that way. People can actually compete to see whose life is more stressful, and therefore who is more resilient, who is more noble, who is more committed, because they're putting up with more stress, because they are shouldering more in their lives. Far from seeing that as disease promoting as it actually is, we often end up celebrating it. And so this insidious upstream trio is so often at play in step-by-step precipitating disease. And so you can start to understand why knowing the science of functional medicine, knowing that, okay, IBS is a gut dysfunction. These are the symptoms. These are the imbalances. These green boxes are what I have to find and treat. That is valuable, but it is not close to enough to being truly capable and confident in creating amazing, lasting clinical outcomes using functional medicine in your practice. And that's what we're really passionate about at SAFM. Because if you think about the cases that I've just reviewed, right? Obviously, Joanne's case involved in particular the notion of food sensitivity that was both created by and also created more intestinal permeability that actually set off other food sensitivities. And upstream from this, the role of 12 years of estrogen containing oral medication that contributed to that permeability. And also vitamin D deficiency contributing to that dynamic, and also quite a bit of NSAID use that she had been pursuing over the years in order to handle the headaches and the intestinal pain that she was experiencing because of the bloating and distension. You can start to see that there are different puzzle pieces at play for Joanne. Well, what about Marilyn? Right? We talked about the fact that Marilyn in particular was struggling with maldigestion and also some dysbiosis. And in her case, quite a bit of gallbladder emptying challenges, and therefore also some fatty acid and fat soluble vitamin maldigestion, which was causing a lot of gas and flatulence. But upstream from that, we see in particular insulin resistance, fatty liver. Marilyn was also struggling with inadequate levels of magnesium. She was clinically deficient, which was undoubtedly also affecting her motility. And going even further upstream, this ongoing exposure to a tremendous amount of xenoestrogenic, endocrine disrupting chemicals. And in Jose's case, again, a completely different set of puzzle pieces. For him, a different type of maldigestion, different reasons for dysmotility, and going upstream and discovering pancreatic insufficiency and insulin resistance, but also history of sympathetic dominant nervous system mode that was being exacerbated in his particular case by suboptimal levels of vitamin B12, which is really quite common as we age. And upstream from that, disordered breathing, which is an acute stress on the body, acute. And obviously the insomnia and the lack of deep restorative sleep that would otherwise promote. You can start to see the many, many, many different clusters of puzzle pieces that you can see in cases of IBS. And so I do want to give you some additional material, and I've just pulled a few slides here from some of our clinical courses. The notion of pancreatic insufficiency, and that exocrine pancreatic insufficiency is often at play in individuals who have both insulin or non-insulin dependent diabetes, both metabolic and autoimmune. And so we want to be looking for this particular dynamic. We always want to be considering metabolic dysfunction in every gut case, and we always want to be considering gastrointestinal dysfunction in every diabetes case, looking across those classic silo boundaries of surgical medical specialties. I think it's also really essential that we as a community all become quite savvy about the role of stress all on its own, with no other exacerbating factors in creating disease. And that includes GI disease. I think this is the type of thing that many practitioners know or assume on a fairly superficial type of level, but it actually is a wonderful use of time in order to do a deeper dive. And in the footers of some of these slides, I've given you just a few curated, peer-reviewed, full text articles that you're welcome to explore. But really understanding just how much chronic stress promotes disease, and the fact that people do as well as they do is actually an incredible testament to how resilient the body is, and that we cannot expect resilient healing without either us or someone else in our practice or in our referral network forming a good clinical partnership with the patient in order to educate, inspire, and empower them about acknowledging their stress and actually doing something about it, following through with accountability and support to make sure that they are able to do something about it, so that their relief is not just for 2 or 3 weeks or months and then they're back again. And it's the revolving door of GI disease that never gets real resolution, in part because people never got the awareness and the support they needed to get at the roots of the day-to-day habits and choices that are actually promoting disease. That type of support and work is within the scope of applied functional medicine. And you don't have to do it all as a practitioner. We actually teach quite a bit about how to be successful doing this work without burning out, because overwhelm and exhaustion is a huge problem in the profession of functional medicine in any modality. We are big fans at SAFM in multimodality partnership and collaboration. So someone in the clinical encounter needs to be doing this type of engagement and coaching and resource support and accountability type of work. Maybe that's you, maybe that's someone else in your practice, but it is truly necessary if we're going to help people to actually get well and stay well. Eating hygiene, again, not optional. Way too many people inhale their food. They are quick to chew it in as few bites as possible and then wash down large pieces, right? Big chunks of food, and just expecting their body to deal with it. And then they wonder why they're exhausted, why they have acid reflux, why they're bloated, why they have early satiety, why they have belching. This is pretty much the logical scientific expectation. We need to treat eating hygiene as a necessary healthy habit, just like sleep or movement. Because I've been amazed at the number of cases of really entrenched chronic acid reflux or IBS that dramatically resolves with this one lifestyle change alone. But it's not enough to suggest that someone do it. People often need to be taught how to do this. And you can use handouts, you can use videos, you can use group workshops and programs, which is actually a lot of fun. And people become much more galvanized to make personal lifestyle change when they do it in community, when they have support, when they don't feel alone in doing this. When we give them guidance on how to do it with their family, both adults and children, that makes it fun, can turn it into a game, and therefore make it much more likely that it goes from being a good idea to something that actually becomes a new habit. Maldigestion. Certainly you can refer to this list later on. Again, just a slide from one of our courses. Maldigestion is not just about do I have enough stomach acid, or do I still have a gallbladder? But there are many critical aspects of optimal digestion and absorption. And we need to always remember that whatever we don't quickly digest and absorb on our own from our diet is excessive food fodder that many different opportunistic species overgrowths are going to try to take advantage of. And especially if a person is stressed or not well rested, that overgrowth can become dramatic or persistent, and in a fairly straightforward way, become chronic, maybe even severe IBS. The dynamics at play don't have to be super esoteric or advanced or out there. So often what people are struggling with is fairly straightforward. We just need to look for it and open our minds to be able to find it, and not stopping with the first or the second root cause that we find, but really looking for that whole chain of interconnectedness and all the puzzle pieces that are at play for a unique individual. Enhanced intestinal permeability. We've got to expand our view on what causes this and what do we need to do to resolve it. Certainly, given our classic modern lifestyle choices, some degree of loss of barrier function in the intestines and immune hypervigilance and systemic inflammation as a result of it is becoming, unfortunately, increasingly common. But we're not always casting a broad enough net and looking at what might be promoting it. Too many practitioners think only about antibiotics and gluten. And if they don't eat gluten, or if they haven't taken antibiotics recently, it's probably not an issue. And that is, of course, not true. There's an increasingly large array of testing available today where we can look at whether or not systemic antibody levels are elevated to substances that should be largely retained in the gut. And if systemic antibody levels are elevated, then by definition, there is an overexposure to those, and the immune system is appropriately being hypervigilant against it. But especially in terms of longevity and prevention of disease, this is certainly a critical place to focus. And any of these types of topics, by the way, are wonderful things to use for a group program or group visits using insurance coverage. A really powerful tool, by the way, of how to use functional medicine in managed care practice and make money doing it. It can be done. But these types of educational programs and step-by-step, covering just a couple of topics at a time and over a period of 2 months or 4 months or 6 months, really shifting a group of patients' perspective and habits and outlook can have a lasting effect on their health. And by supporting them in that context and having them participate in your practice in that way, reducing the burden of disease that they suffer from and that you end up having to assess and treat. So all things are interconnected. And if we want to help people get at the roots of their unique case of a disease, you've seen now through the lens of IBS and even just the few examples I shared, I could have given you 50 different examples today, and they would have been markedly distinct in terms of what is at play. It's part of what makes the investigation, the functional medicine lens so fascinating analytically and intellectually. We must cast a broad net and think about asking, who is this person? And not falling prey to the quick fix mentality of what's the right diagnosis? What's the right label? So I can jump to a standard of care and treat it, which may give them some short-term relief. It may help to manage the disease, which is valuable, absolutely, and a huge blessing. I absolutely want to acknowledge that. But if we want to transform the effectiveness and affordability of healthcare, it's just not enough. We ultimately can give people back to themselves through education, inspiration, empowerment, community, to reduce the overall burden of disease so they may better understand in their unique life system what has been causing their suffering and how they can stop it. And I want to end here with just one critical concept, which is about the reality of the roots of disease of so many of the patients you serve in your practice. Very often, the people who are struggling with entrenched metabolic disease or entrenched immune dysregulation or entrenched GI disease, there is nothing at play in their case that is the result of an inherently broken body part. Instead, what is very often at play is that people are making day over day choices, day after day, month after month, year after year, that end up making them stressed, toxic, inflamed, infected, malnourished, and unrested. And the logical outcome of those choices is disease. That's not a surprise. That is the logical outcome of those choices. Given enough time, there will be some type of chronic, likely inflammatory disease. But what's fascinating is that people who are making those day-over-day life choices come to you because they want to be having a life experience that those choices cannot possibly create. So they're making those choices, but they want to feel awesome and be thin, be lean, have high vitality, have lots of energy, eat anything they want, have perfect bowel movements, not be bloated, thrive and grow and flourish and have high libido and great fertility and awesome orgasms and never get sick and have quick wound healing, right? They want to have all these life experiences, but they're making the choices that are not capable of creating that life experience. And they're not going to know that until we teach them. And this is where crap food, toxins, and stress are so often at play in creating the burden of disease in our practices, especially in the primary care realm. And so this is where we have a huge opportunity through proactive engagement to teach people about these fundamentals. This is critical inside the scope of applied functional medicine. I'm a big fan of pictures because this is what people are eating. And we need to teach people that this is a lot of calories, a lot of chemicals, a lot of marketing, a lot of colors, but there's not a lot of micronutrition here. We have to teach people what is actually in food. And we as practitioners need to really learn what are the most common culprits in food that are creating specific downstream functional imbalance and disease symptoms. Again, regardless of your modality, I believe this food and the manifestations of food is an essential component for all practitioners to master. And we teach a huge amount about this because it is too often not covered richly enough, and that contributes to disease recurrence. We also have to teach people about the huge burden of toxicity that is unfortunately ubiquitous in many of our cultures, many of our societies, and just how much this is impairing our physiology. We are designed to deal with a certain amount of toxicity, but the burden that just the average person wrestles with today is tremendously disease promoting. And this is, again, something that practitioners can really learn to master. And in particular, in its impact on cellular damage and mitochondrial dysfunction, how this can be a key puzzle piece in almost any chronic disease presentation. Toxicity is contributing to a massive amount of immune hypervigilance, like asthma and allergy and autoimmune disease. It is at play in a tremendous amount of fatigue, right? That ubiquitously generic frustration symptom that can have so many different causes, but where mitochondrial dysfunction is at play. And obviously that can be exacerbated by all sorts of things affecting basal metabolic rate and ATP synthesis, whether it's inadequate CoQ10 or insulin resistance or hypothyroidism or too much cortisol. These are what we need to consider with regard to impact for anyone who's just living a normal life and using the same products, putting themselves in the same environments that is going to expose them on a day-over-day basis to an incredible diversity of toxins. But I really think the most ubiquitous, the most insidious category of the three is stress. I love this cartoon. I actually joked with the cartoonist about it because it is so sadly hilarious that even relaxation is something we want to have a sympathetic dominant approach to. Our cultures are so full of impetus and reward and celebration of go, do more, better, faster, now. And true relaxation, true rejuvenation and restoration is dishonored in so many of our cultures. And we need to be teaching people. And I'm a big fan of teaching using simple stories and analogies. We love to offer lots of those to practitioners, because if you try to teach your patient using erudite scientific language, medical ease, you may impress them that with your education and your wisdom, but you're not going to help them to understand and have a real aha about what is at play in their body in a way that they can never forget, that they get galvanized to change, to do something about. And I love diagrams like this, especially hand-drawn ones like this, that are easy to access, where we can understand the difference between which parts of our anatomy and our physiology and our biochemistry are being triggered when we're fighting, flighting, and hiding, versus which ones are being emphasized when we're resting, digesting, healing, and making babies. And that so often the symptoms that we have may be natural manifestations of being in a sympathetic nervous system mode too long. For example, this is a critical component of patient education. But also as practitioners, understanding that stress goes way beyond the mental, emotional, family, relationship, job types of stress categories that people can wrestle with. And that we must become quite capable of investigating and identifying physical or physiological stress, especially where it might be hidden. And I've highlighted for you in blue, throughout this presentation, actually, some of the most often overlooked categories of chronic stress that are actually promoting disease. And it may be the reason why your patient, despite all of your other interventions, is just not getting well, or can't stay well. They're on the revolving door, the merry-go-round of disease and suffering. And so these are the types of things we can begin to look for and cast that broad net with beginner's mind. And so when we're talking about stress, and in particular how it affects parasympathetic transmission in the body, and in particular the behavior of the vagal nerve transmission, pretty much everything important that happens in the torso needs good vagal transmission. And that is richly true in the gut. And if it's not happening, then people will struggle with some aspect of dysmotility, maldigestion, malabsorption, and dysregulated immune function in the gut. But yet there's actually a remarkable amount of research, especially in the past 5 or 6 years alone, 5 to 7 years alone, that shows us that there are fairly straightforward habits, practices, behaviors that can help to induce parasympathetic transmission and improve vagal tone. These are things you can teach your patients to perform on a regular basis. You can make it important by actually writing it out on a prescription pad and helping them to understand that this is not a superficial optional thing. It is a powerful interventional tool in order to help them, their physiology to work as it is designed. And so I'm going to close with that. I'm sure there's some questions, but just to summarize here, I hope that you picked up some pearls, some insights, some ahas with regard to using both art and science in sustainably resolving gut dysfunction and imbalance in the patients and clients that you serve. Because it's not enough to treat the stool test. It's not enough to treat the symptoms. We've got to cast a broad net and find the unique puzzle pieces and resolve them in a sustainable way, which also requires that savvy partnership and accountability and follow-up, sustained engagement with the patient so that they can get educated, inspired, and empowered, and find a new community that helps them to make different choices. So I thank you very much. And I'm Sarah. I'm happy to answer questions that might have been raised or that folks want to raise here. And certainly if I don't know the answer here off the top of my head, I'm happy to follow up later. But I just want to say thank you for the opportunity to present. sharing with you just a little bit, a tiny, tiny taste of what we teach at SAFM. And if any of the practitioners present today are interested in really bringing applied functional medicine into your practice, certainly we would be honored for you to consider SAFM for your advanced training needs. We are accredited and happy to meet your continuing education credit needs as well. So thank you so much.
Thank you, Tracy. That was a wonderful presentation. We did get a few questions, and we'll try and get to as many as we can. The first one is, what are your thoughts regarding multi-strain versus single-strain probiotics?
Oh, that's a great question. So I think it really depends on what you're trying to achieve. And also the state of the person. So probiotics can do a lot of different things. And we have to remember that there's that planetary world of microbes in our gut, and they are doing a lot of different things. They're helping us with digestion. They are helping us with detoxification. They are both promoting inflammation and resolving inflammation. They are both degrading the biofilm and creating the biofilm. There's a lot of synergistic activity happening. And so if you're talking about using a probiotic, maybe for health and prevention, right? For overall just keeping good health, avoiding illness. The whole notion of using a variety of species, some histamine producing, some not histamine producing, some that are immune stimulating, some that are not, right? This rich diversity may be very appropriate. But in other cases, if a person is already crazy inflamed, they've got body parts that are struggling or dysfunctional, or they're about to lose body parts because of the amount of inflammation, we want to use great care in making sure we're using species, for example, that will help to resolve inflammation, that are going to help, for example, by increasing T regulatory cells. If you are in a clinical plan where you're trying to maybe promote more detoxification, you're going to use different probiotics than if you're trying to boost immune function to finally get rid of high viral load, for example. And by the way, that speaks to the wisdom that too often in a clinical plan, we're trying to do too many things at one time. We talk about functional medicine intervention like peeling an onion. You peel an onion one layer at a time. You're never working on more than about 2 layers at once. But too many practitioners try to heal the gut, address dysbiosis, run a detoxification program, change the diet, boost nutrients, resolve arthritis, and clear a fatty liver, all at the same time. That's not going to work. The body will not effectively, or much less optimally, do all of those things at one time. We need to work in layers, which also keeps people from being overwhelmed and overloaded. The number of patients who say, I went to a great practitioner, I got a lot of testing, I got a lot of recommendations. Here's my list of 25 things. I was overwhelmed. I didn't know where to start, or I was told to do them all at once, and I did, and I felt worse quickly, so I didn't do anything. This is way more prevalent in functional medicine than we might realize. And so who is this person and what do they uniquely need, I think is an important consideration in terms of what is the best probiotic. And it's why I love, for example, the rich diversity of probiotics that Fullscript offers. It's a great catalog to help you consider, what does this unique person need?
Great, thank you. The next question is, do you feel the RDAs for micronutrients are sufficient for our current needs?
No. That's an easy question to answer. Let's see, how do I answer this shortly? The notion of how much of a given nutrient does the average adult need in order to not get certain deficiency diseases is crazy different question to ask than how much of a given nutrient does this unique person need at this point in time, given their life system? Those are radically different items, because there's not that many people who are actually representative of the average adult in any given society. But if you take a given person's genetics and the way they sleep, their stress load, their toxic load, their infectious load, their relationships, the community, the environment they live in, that they are sleeping in and breathing in their home, of course, their nutrient needs are going to be different in terms of what helps them to not only not get disease, but I think the much bigger question is, what helps them to thrive? What helps them to get what I call the real definition of health, which is resilient vitality in the face of day-to-day life challenges? Those are very different questions and different thresholds to work toward. And this is why I'm a big fan of looking at functional sufficiency of nutrients, because it's letting you know, in this unique person's body right now, is there evidence that they're not getting optimal levels of this nutrient to help their body thrive? Then our recommendations can be really quite targeted and appropriate for the individual.
Great.
I'm sorry, I'm still sharing my screen here, aren't I? Let me.
Oh, no problem. We are going to get to one more question for today, and then we are going to have to wrap up.
Sure.
So the last one is, does your course have any business aspect to it? How to, for example, how to market functional medicine programs to patients?
Oh, it's a great question. So we have the program includes two what we call semesters. And in between those two semesters, and the semesters are rich with clinical content, lots and lots of case practice, we have what we call the clinical skills intersemester. And this is all about the work of using what you've learned in your practice. So we teach about all sorts of different business models, clinical working models, using cash pay versus managed care, insurance coding, these types of things. So we give an overview of a huge amount of those types of options. Now, what we don't do is like a super deep dive into just how to market your practice. We recommend a lot of resources for that, and we give some knowledge and some key practices in a lot of different areas in the business realm, but we don't do a huge deep dive into real specific sort of categories within that. But our students do learn quite a bit from one another around not just which other more advanced program to pursue. There's a lot of experience. That's part of the advantage of having a huge student body. But often one of the best opportunities to learn is just by interacting with other practitioners and learning what they've done and what works and what doesn't work. I don't think people always need to invest in another high-priced program. What they need is time and space to really ask questions and learn from people who are doing it and who are successful, because they have wisdom on what works and what doesn't work. And so I'm a huge fan of the value of sort of the tribe community, if you will, and shared expertise.
Wonderful. Well, thank you so much, Tracy, for your time today and for that informative presentation. We will be sending out the recording and the slides from the presentation after. So if anyone has any follow-up or questions, please feel free to reach out. But thank you once again for your time.
Yeah, thank you so much, Sarah, and thank you, Fullscript, for the opportunity. I appreciate it.